Stanford University.
Good evening, everyone. Glad to see you here again. So last week, as you remember, we had an opportunity to hear from Dr. Norm Risk, who reviewed the pulmonary respiratory system. And you may remember that when he was giving his presentation, he talked about the place where the epiglottis becomes really important because that sort of bifurcates the connection between the respiratory tract and the gastrointestinal tract. And so tonight we're going to be focusing on the GI tract and how it works and when it goes awry. And it's a bit ironic that our speaker this evening, Dr. J. Pasricha, who joined Stanford 2 years ago to lead our gastrointestinal division in the Department of Medicine, actually began by going down the respiratory tract. So after he completed his training in India and came to the United States and did some residency, he started out in respiratory medicine and critical care medicine, just like Dr. Risk last week. He did this at Tufts in New England and Boston, and then something happened, and he decided that he went down the wrong tube. So he must have come out, and he moved south and went to Johns Hopkins, where he decided to go down, bypass the epiglottis, and get into the GI tract, where he's been ever since. So he has made his life journey focusing on the GI tract, and actually has uncovered some very, very important clues along the way. Something that you probably don't know but would be interested to know is that just like we think, and you've heard in past discussions, we have our brain functioning in thoughts and various activities. Well, there is a, if you will, almost separate nervous system that operates the GI tract as well. And so for those of you who had dinner before you came, your GI tract is already functioning, and for those who are going to eat like me after you get home tonight, you'll learn a little bit about how it's working, or perhaps even how it's gone awry. So there we are. Tonight's presentation, Jay Pasricha.
Thank you very much, Phil. It's a pleasure to be here, and I want to applaud all of you who braved this stormy weather to come in and listen to what is arguably the most important system in your body. Okay. I knew everybody would say that, but today I'm going to actually prove to you that it's true. So what we'll talk about today is an overview of the structure and function of the gut, and as Phil mentioned, I would like to emphasize the role of the gut's nervous system. And then we'll take a brief history of your last meal. How many of you have eaten already? Okay, well, this talk is then going to be very educative for you. Then we'll talk a little bit about the gut's lining, because that's really how the gut interfaces with its environment, and it's a very, very important aspect of the digestive system. We'll go on to enteric microflora, which is a very hot and emerging field, not just in gastroenterology, but in all of medicine. Talk about the gut's immune system, and then finally end with the brain-gut axis. As you can already see, the gut is not just a single system. It's actually a composite of many, many different kinds of systems, from the nervous to the immune to the microbiological. And it's really a very interesting area to be immersed in, and I hope you will enjoy it as much as I have. So the general approach will begin with an outline of the organs that make up our gut. And conceptually, we look at these as either luminal organs, those that are hollow, the so-called tubes, which most people think synonymously with the word gut, and then the solid organs, which are also part of the digestive system, and these include the liver and the pancreas. Now, in the interest of time, I'm not going to spend a lot of time on the liver and pancreas, and perhaps that can be the subject of a later talk. We'll focus really on the luminal organs. Now, this cartoon, of course, doesn't give justice to what's really the true picture of what's going on in our gut. And I thought I'd start with this video, which is a actual endoscopy of a patient. And I do this for two reasons. First, because I think it illustrates what our guts look like much better than any cartoon can. And secondly, because it highlights the importance of this tool, the endoscope, which has really revolutionized our specialty, not only allowed us to diagnose and treat conditions, but really further our understanding of the biology of the digestive system. So here goes. We're positioned in the esophagus, which is the tube just past the epiglottis that Phil referred to, and we are pushing the scope down, and we come up to the GE junction, and you can already see that the color changes. We're now in the stomach, and this is the distal part, the further part of the stomach. This is us looking back at how we were entering the stomach, so-called retroflex view. And these are the folds of the stomach. And in the distance, you can see the pylorus, which is the opening to the small bowel or the duodenum. I just wanted to give you that as an introduction because we will use these images as references as we go along. So let's start with the gut nervous system and how it works. This is really the answer to the question of what controls the gut. Now, many of you feel that the gut is sometimes out of control, but actually it has two sets of nervous systems that control it. The one that is more commonly known, which is the central nervous system, the big brain inside our heads, really is involved in control of the gut in two main places, which is at the beginning and at the end. And that is where the gut really interfaces with the external environment. And it's very important that you have multiple controls because if you don't, things can really go awry, as we'll show you. So the brain in our head actually starts the process of regulating gut function very early on. Now, I noticed a few of you hadn't eaten, but perhaps if you can, those of you who haven't eaten, can think of the meal that's awaiting you after this lecture. You will have triggered what we call the cephalic reflex. Just the thought, the sight, the smell of food triggers this reflex, and the brain up here starts priming the gut, so to speak, in anticipation of the meal that is coming, or hopefully is coming. And this results in a stimulation of the salivary glands. It results in stimulation of the stomach to produce acid, and it may be responsible for the rumbling of your intestines that you often hear when you're hungry and are thinking of a good meal. So that's the cephalic phase. But more importantly is the fact that the brain gets involved in controlling the swallowing process. As Phil mentioned, and as you may have heard last week, the epiglottis bifurcates this foregut into the esophagus, the food pipe, versus the respiratory tract. And it's very important that as you swallow this bolus or this collection of food material past this epiglottis, that it doesn't go down the wrong way. It doesn't either go down to your airway or it doesn't come back through your nose. And this is really where the big brain exerts very fine control of this process, making sure that there is safe passage of the food down to the esophagus. And in fact, there is a center in the brainstem that is devoted just to swallowing and controls many nuclei, which through multiple cranial nerves really make sure that the swallowing process is normal. This is one reason why patients who have strokes or other neurological disorders often have difficulty with swallowing, and you may have seen some of these patients, they can have difficulty even swallowing their secretions, things go down the wrong way, and it's really a big challenge to try and help them maintain nutrition. So we'll come back to the other end in a few minutes, but then the question arises, what controls the rest of the gut if the ends are controlled by the central nervous system? And in fact, there is another nervous system, one that many of you may not have heard about, what we call the enteric nervous system. And when I was growing up as a kid, my mother often used to berate me for having no brains at all. And one of the biggest satisfactions I found when I became a gastroenterologist was to go back and tell my mother, you were wrong, not only did I have one brain, I actually had two brains. And this is a tale about the second brain, the enteric nervous system. To understand this, let's just begin with an overview of how the gut is organized. If you take a section of the gut, it's a tube, and if you cut it, slice it like this, you'll see it consists of many concentric layers, pretty much in the same fashion from the esophagus all the way down to the rectum. The inner layer is called the epithelium, and underneath that is the submucosa. And then you have two layers of muscle, an inner circular muscle and an outer circular muscle, outer longitudinal muscle. This is just another representation of the same process. If you look at the gut and you peel away the layers, this is the inner mucosa, and these are the circular muscle and longitudinal muscle layers. Now, sandwiched in between these two muscle layers is really the brain, the enteric plexus, which is the major part of the gut's brain. This controls the motor activity of the gut. In other words, it controls the contractions, controls the relaxations, responsible for spasms, is responsible for pushing food down the gut. And the other component of this is the submucous plexus, which lies just beneath the epithelium where the glands are, and this nervous system controls the secretions of the intestine in response to food. The enteric nervous system is a surprising nervous system for those of you who are not familiar with it. It has 100 million neurons, more than the spinal cord, for instance, and these are all contained within the wall of your gut. It's capable of performing very complex functions, including sensation, processing the information, and coming out with complex motor or secretory algorithms. It has multiple synaptic mechanisms, multiple neurotransmitters. Some of you may not know, but more than 90% of the body's serotonin, for instance, is found in the gut. More than 50% of the body's dopamine is found in the gut. There are many neurotransmitters that have yet to be discovered in the brain that may first be identified in the gut. So this nervous system is actually very, very important, not just for digestive function, but for its implications for other nervous systems in the body. So what does it look like? If you take a photomicrograph, this is what it looks like. Here is the outer muscle layer, here's the inner muscle layer, and this is the enteric plexus that controls the contractions sandwiched in between. This is a scanning electron microscopy showing the neurons on top of the muscles. And conceptually, it's different than the kinds of nerves that control your skeletal muscle or the muscles of your limb. There are two types of nerves that we find in the enteric plexus, those that cause the muscle to contract and those that cause it to relax. At any one time, muscle in the gut is under the influence of these two opposing messages, one that's causing it to relax and one that's causing it to contract. But it's not just the nerves that are important for muscle relaxation or contraction. There's a third kind of cell, which we call the interstitial cell of Cajal, ICC, which is named after the Spanish neuropathologist, neuroanatomist. And this cell, we now know, actually controls the rhythm with which the gut contracts. And you can actually record this rhythm in human beings using a machine that we call the electrogastrogram, somewhat similar in a very crude way to the electrocardiogram or EKG. And when you do that, you actually see these nice, in a normal person, a nice slow wave rhythm, 3 cycles per minute. This is a power spectral analysis just showing over time nice peaks of this rhythm. And then in patients who have diabetes, particularly those who have problems with their stomach, you can see that this rhythm is disrupted and it's completely chaotic, and that results in problems with their stomach not working properly. So the muscle and the music of your bowels is really complex, but consists conceptually of the muscles, which is like the piano or the organ, the interstitial cell, that is the metronome, and the enteric plexus, which is the organ player. And together they make very beautiful music, and some of you may be listening to it already. So this is really the brain, and this is the ENS, the enteric nervous system, and it controls many reflexes in the gut. We talked about contractions, but it's also responsible for secretion, as I told you, as well as regulating the amount of blood that is coming into the gut in response to a meal or other stimuli. Let's just look at the peristaltic reflex to illustrate this. The peristaltic reflex is a very basic motor mechanism by which the bowel contracts. And it contracts when you distend a segment of the bowel, either mechanically. So if you swallow some food, it will distend a segment of your bowel. Or it contracts in response to chemicals that you ingest, which are part of the food. These chemicals, or the stretch, in fact, cause cells that line the mucosa that contain serotonin to be activated, resulting in the release of serotonin. This serotonin release then triggers the activity of nerves in the enteric nervous system that causes a complex series of signaling going up and down the gut. The result is that behind the bolus, there is a contraction, so that generates a pressure head, pushing the bolus forward. But more importantly, or equally importantly, ahead of the bolus, the gut has to actively relax, not simply stretch passively, but actively relax so as to allow the bolus to go forward. And this is what we call the peristaltic reflex, and this is just another way of illustrating it. You have a bolus, you distend a segment of the bowel, you contract behind it, and you relax ahead of it. Now the gut and the enteric nervous system in particular uses this reflex to come up with a lot of programs that are almost wired into it. And these programs depend on, one, whether you're eating or you're fasting, and two, which part of the gut we're talking about. So the fed programs vary with the region of the gut. You have the esophagus, which is mainly associated with transit of the bolus, a very quick transit. The bolus moves within seconds or less from the mouth down to your stomach. In the stomach, it takes a lot longer because part of the stomach's function is to store the food instead of just dumping it into the intestine. Also, as we'll show later, the stomach participates in grinding the food down. And then in the small bowel, there's a program which we also show, which is called mixing. And then finally, the large bowel, which is again transit, but much slower, and exit. And then in between these fed programs, there's what we call the fasting program, which is really like a housekeeping program. Anything that's left over that's not digested is swept out of the body in cyclical giant contractions that move debris from the stomach all the way down to the small bowel. So let's just now go through the history, as I said, of your last meal. And we'll talk about the process of digestion. And digestion is actually a very simple concept, but it's very complicated as a process. Essentially, what you're doing is converting energy of one form to an energy that your body can use. So you take these energy particles, which we call food, which are large particles. We chew them down a little bit. And then we add water, ions, enzymes. We mix it, grind it. The end process is small absorbable material. And then whatever is left over that we can't use, we eliminate it. And digestion actually is not only the breakdown of the large particles, but absorption of nutrients, absorption of water, and as I said, the elimination of waste. It begins in the mouth. As many of us tell our kids, chew your food properly, and there's a reason for doing that. You want to reduce the size of particles. You want to form a proper bolus. Some digestion in terms of starch and lipid breakdown is initiated there, but saliva also is antibacterial and can neutralize some of the reflux acid in the esophagus. The real action, however, begins in the stomach, once the bolus reaches the stomach. And I'm just going to show you what the stomach does to grind the food down. So here's a bolus of food coming down into your stomach. Your stomach first relaxes to accommodate that so you don't feel full that easily. And then it starts pushing that bolus towards the pylorus. And as it does so, the pylorus is partially closed. The pylorus is the region between the stomach and the first part of the small bowel. It's partially closed.
Does that happen?
Sorry?
How quickly does that happen?
How quickly does the stomach start contracting?
Moving the things from one end to the other of the stomach.
So the whole process should be over at the most 4 hours of a normal meal. Your stomach should be almost completely empty by the end of 4 hours. Half of your meal is cleared by about an hour and a half. So the important thing here is that the stomach will not allow the passage of large particles into the duodenum. It will keep pushing them against a partially closed pylorus, which acts like a sieve, and the stomach is acting like a mill against the sieve, and it keeps working normally to crush these particles down till they're about 1 or 2 millimeters in size. Considering the size of a bolus that we normally eat, that's a huge reduction in size, and it does so through very fine, intricate mechanisms that I have just shown you. But here's a video of an actual human stomach, and this is the antrum, this is the middle part, here is the pylorus, and that's the duodenum. And there's contrast in the stomach. And the idea is to show you that this contraction is taking place against a partially shut pylorus. Very little contrast is actually flowing into the duodenum. And the stomach is really working right now to grind things down. And if you actually put some non-digestible solids like we have here in the stomach, you will see that they keep being pushed against the pylorus, but they will not make their way down into the duodenum because their size is too large. And they'll go there, and they'll come back, they'll go there, and they'll come back. And because they're non-digestible and they're plastic, they can't be broken down during this phase. Eventually, all the food will have been broken down. This plastic material will stay in the stomach till we get to the fasting program, which is the housekeeping program. And that's when things are going to be swept out. Okay, so what controls this process? It's a very tightly controlled process. As I said, the stomach serves as a filter and a valve, allowing particles of only 2 millimeters in size or less to pass through, with an average caloric delivery of about 150 calories per hour. And this is very finely tuned and partially dependent upon the size of the meal, partially dependent upon the nature of the meal, the viscosity of the contents, the fat contents. But suffice to say that this process is tightly controlled and under the feedback of many different mechanisms, which I will talk to you about very shortly. One of these being what we call the ileal brake. As soon as food starts hitting the small bowel, signals start going back to the stomach. Okay, we're receiving the first supply of nutrients. You can slow down now, because we don't want to get overwhelmed in our capacity to absorb this. Yes, ma'am, I see. Can I just finish this section? I forgot to tell you at the beginning. I'm going to break this up into sections. I want to finish that, and then I'll open it up for questions. If you just give me about 5 more minutes, and we'll open it up for questions. Thank you. So now this food is starting to get into the small bowel. And the small bowel has several different parts, but one of the most important parts in terms of the process of digestion is what we call the duodenum, because it's here that a lot of the mixing that's important for breakdown of foods chemically takes place. And that's because the duodenum is where both the liver ducts open as well as the pancreatic ducts open. And both of these supply essential ingredients that are necessary for digestion of absorbed food. And so, as I say on this slide, the duodenum can be likened to a master brewer. You have this food, and it's got to really get into this process akin to fermentation, but it has to control a lot of different inputs that go into this process. So here's the gastric food, we call it chyme now, which is coming out of the stomach, and then these are the enzymes that are being produced by the pancreas, that are being regulated by local reflexes. This is the bile that's coming out from the liver that's being regulated by local processes. Gastric contents are very acidic because the stomach produces acid. That has to be neutralized by the production of bicarbonate in the small bowel, otherwise the enzymes won't work. And all of this process has to be monitored, looking at the pH, looking at the osmolality, looking at how much volume there is, and this is where the enteric nervous system is sensing what's going on and relaying feedback through either hormones or nerves that are controlling this process. So a lot of enzymes are involved in this process, and this mixture, amylase and lipase, actually begin before they even come into the duodenum. The stomach produces lipase, and the saliva contains amylase. But a large part of the enzymes responsible for breakdown of fat and protein come from the pancreas. And the pancreas secretes these enzymes not in an active form, and this is very important. It secretes them in an inactive form. It's only when they get into the small bowel that they become activated. And when they get activated, then they form all these various enzymes, the list is very long, which act on various segments of these food particles and breaks them down into simpler constituents. And I said it's very important for these enzymes from the pancreas to be secreted in an inactive form. These are the most powerful enzymes that we know in biology. They can chew up almost any tissue between the trypsins and other proteases as well as the lipases. And what happens sometimes is in the pancreatic cell, under certain conditions, for instance, we know with certain forms of alcohol intake or in the presence of gallstones, this process is bypassed and the enzymes actually get activated within the pancreas itself, and that results in what we call pancreatitis. And you have this normal-looking pancreas that is then undergoes a process of what we call autodigestion. The enzymes are now active within the pancreas and cause acute pancreatitis. And over time, or with repeated insults, this can result in chronic pancreatitis. Now, again, these enzymes are coming in, these secretions are coming in, the food is coming in. It all has to be mixed up properly. If you're not going to mix it up, then the enzymes are not going to get a chance to really attack the food. And that's where, again, the contractions come in. This is the fed pattern of the intestine. This is the segmentation, the mixing and sloshing of the enzymes. And again, this is an endoscopic view that gives you an idea of the active contractions that are going on in the duodenum. There's no food here, but the duodenum is still contracting, and it gives you a clearer vision of how it actually works. And so with all of this mechanical and chemical interaction, we start seeing the breakdown of these complex chemical molecules, such as the starches or starch-like sugars, for instance, under the influence of these enzymes, to smaller molecules, and so on. The process occurs with proteins as well as fats. Now, there are some therapeutic opportunities for those of you who want to lose weight, and you're familiar with this drug Orlistat, known by its brand names shown here, where you want to actually inhibit some of these enzymes, and Orlistat actually inhibits lipase, which is an enzyme produced by the pancreas responsible for fat digestion. So the result is, instead of the enzymes being able to act on the fat particles, they are blocked by this drug, and this results in a certain amount of malabsorption of the fat, and then the fat then goes on to produce some diarrhea and makes you lose weight. It is one of the messier ways to lose weight, let's put it this way. Now, in this process, the liver is not a passive bystander. It actually also participates, not to the same extent perhaps as the pancreas does, but importantly. And it does so mainly by producing bile salts. Bile salts are salts that are present in bile, which is a complex fluid. And bile is stored in the gallbladder, awaiting a signal that it's time for the gallbladder to contract and eject the bile into the duodenum. What bile does, it acts as an emulsifying agent. So it takes these big droplets of fat that are coming out of the stomach and breaks it down to smaller particles that the enzymes can then act on more efficiently. And when the fat is broken down, bile salts are also help repackage those fats into what we call micelles, which are small particles that are more efficiently absorbed by the cells lining the small bowel. So bile salts are important in fat digestion in particular. And bile also serves as a way for the body to get rid of cholesterol, which is made by the liver. And bile salts are important in the process of maintaining the cholesterol in a soluble state. So if you look at this triangle here, whether cholesterol stays in a soluble form depends on the concentration of the bile salts, the concentration of another detergent, lecithin, and the concentration of cholesterol. In the gallbladder, bile is concentrated, and in some individuals, either it's concentrated too much because they have a genetic problem that cholesterol is high, or the gallbladder doesn't work very well, and the bile stays in there longer, allowing more concentration to happen. The result is that cholesterol may precipitate out, and this is what forms the usual variety of gallstones. You can see here a gallbladder that is full of gallstones. So after digestion, once the food has been broken down into these chemicals that can absorb, the smallest amount of particles that they're capable of breaking down into, they have to be absorbed. And here's where the 20 plus feet of the small bowel really is necessary, because throughout the length of the rest of the small bowel, absorption is taking place. And it's not that 20 feet is enough. In fact, it's not. What the gut has to do is to form these layers and folds of the lining, which we call villi, which are really microscopic, tiny folds that increase the surface area of the small bowel 100-fold or more, that really allow efficient absorption to take place. And when these nutrients are absorbed, then they have to be transported, and there is a very rich blood vessel network right underneath the epithelium that carries most of the nutrients away. And there is also a lymph network, which we call the lacteals, where the fatty nutrients, the fatty acids, and the other lipids are absorbed. And these go via the lymph node back into the circulation, whereas the other nutrients go to the liver. And this is an endoscopic image showing you these villi, and you can see how many hundreds of thousands of small villi are there on each fold. And this is really what gives the small bowel its tremendous absorptive capacity. Now, I told you about the fat absorption, so those of you who had the typical US dinner of Big Mac and fries, and if we were to examine your the surface of your bowels, we will see these lymphatics, which are full of this milky fluid, which is the fat. I can see somebody's headed for the salad bar tonight. Okay. Now, as I said, the nutrients, apart from the lymphatics, which take the fat, the other nutrients don't go straight to your heart. They actually are carried to the liver, where the veins actually break down into capillaries again before they go out of the liver. And this is very important for two reasons. First, the liver absorbs some nutrients from the circulation and stores them, such as glucose to glycogen and so on. But also, the liver is a very efficient filtering mechanism for potential toxins that are coming out from the gut. So it's very important that the stream of blood that's coming from the intestines not go directly to the heart, but via the liver. And so liver plays a very critical role in preventing infections or preventing the entry of toxins from the gut, in addition to its role in digestion. And in fact, in patients who have cirrhosis, where there's destruction of the liver and scarring of the liver tissue, there is an obstruction to the flow of this blood coming from the intestine. There's pressure buildup in these veins, and they start backing up, and this results in what's called varicose veins, or what we call varices, which are the equivalent of varicose veins that you would see in your leg, just veins under a lot of pressure, enormously dilated. And the problem with this is not only now there's not enough blood going to the liver from the intestines, but these dilated, engorged veins are at risk for bursting and causing bleeding. So I'm going to show you, and this happens particularly in the esophagus, sometimes in the stomach. And I'm going to show you an example of a bleeding esophageal varix. This is one of the reasons we're often called as gastroenterologists in the middle of the night to take care of cases like this. So here's a varix. This is the lining of the esophagus, and you can see it's actually bleeding here. That's a stream of blood coming, and that's in the stomach. Fortunately, we now have the tools where we can fix this. We can go down with the endoscope with a little cap-like device at the end of it, suction the varix into it, and slip a rubber band on it and choke it off. And that's the commonest way now of treating varices. There we go. It took care of that bad guy. All right. Okay, so we talked about a lot of different things, and I'm just going to wrap up this section by saying there are other factors that I didn't emphasize as much but are equally important, and that's hormones. So the nervous system communicates through nervous reflexes, but also through hormones. For instance, in response to the meal arriving in the duodenum, a very important hormone called cholecystokinin, CCK, is produced, and this results in contraction of the gallbladder, which is why it's got its name, cholecystokinin, but also stimulation of pancreatic enzyme production. And part of this is mediated by direct effects, and part of it is mediated by reflexes that go to the brain. There are other hormones that act outside of the gut. And these are, for instance, hormones that we call incretins. You may have heard of this name, a hormone like GLP-1. This is produced by the intestine in response to the meal. It has some effect on stomach emptying, but it also prepares the pancreas, particularly the cells in the pancreas that produce insulin, and tells them, okay, a meal is coming, you need to start revving up the insulin production. And so this is all being coordinated at multiple levels. And this is, in fact, now a target. This axis is now a target for drugs, some of which you may have heard about, which are really augmenting the effect of the incretins in various ways. Okay, now for the fun part. Okay, so we've absorbed as much as we can. The small bowel has done its job, and what's left over now goes into the large bowel. And the large bowel is very important. It has to get rid of this waste matter, but it's also still about a liter of fluid there that it has to absorb, because otherwise you would lose a lot of fluid every day. So the colon absorbs water and electrolytes and then gets rid of what's left, as you can see here. And it doesn't do this on a regular basis. As those of you who are regular, it may happen once a day or once every other day. You get these giant contractions that move this fecal matter from the right side of your colon all the way down to your rectum. So I won't repeat this too many times. But don't be embarrassed. Everybody does it. Okay. So now that the stool reaches the rectum, and it's very important again. Now, the moment the stool reaches the rectum, one of two things can happen. Usually, you get an urge, and if it's socially appropriate and the timing is right, you're with the New York Times and a cup of coffee, and it's okay. Things happen, but otherwise, you got to control it, and this is where the brain here kicks back in. I told you it works here and also works at the other end. And that's where it's very important, part of the function, is a very important way of maintaining continence. And I'll just show you that process. So this is where the pelvic floor muscles are very, very critical. So when the bolus or the fecal matter arrives in the rectum distends, and that triggers an intrinsic reflex that causes the rectum to contract, and if you don't do anything to stop it, you may have a bowel movement. What you do, if you don't want it to happen, is you tighten this muscle, the sling muscle, which you call the puborectalis. It's part of the pelvic floor. And you really make this angle very acute, preventing anything from moving down to the sphincter. When you're ready, you relax that, you bear down, you squeeze your abdominal wall muscles, you increase the pressure there, and your sphincter relaxes, and you have an evacuation. And we actually can study this in the clinics. Another surprising thing that gastroenterologists do. We put contrast in the rectum of patients, and then we ask them to sit on a toilet, and we x-ray them. And then we expect them, and we tell them to say, relax, just pretend you're having a normal bowel movement. But you can see that this angle here, when you don't want to defecate, is very acute. And when you do, then you start losing that angle. You relax this muscle, and now things will start coming out. Okay, just to summarize this section, and then we'll take a little break for questions. We've talked about the process of digestion, and you can liken it to an industrial process. If those of you are engineers here, start with the choppers, That's the mouth. You go through your blender, acid sterilizer, the reservoir, that's your stomach. Then you go to your reaction vessel, which, as I've said, is the duodenum. You have your detergent supplier and the enzyme supplier, which is the pancreas, the detergent supplier, which is the liver. And then you go to the catalytic and absorptive surface, which is the small intestine, the residue combustor, desiccator, and fellator, and then the emission control device. Okay. So I'll take some questions. I know one of you has been eager to ask me that, so I'll start with you.
Well, going back to the start, when you eat the food, I've heard that it's best not to include liquid when you're eating. Does it make a difference in your digestion if you just are eating food and not drinking amounts of liquid with it?
You mean as opposed to, so drinking after the meal is over, as opposed to drinking with the meal, or not drinking at all?
Drinking with the meal versus...
Yeah, so the question is it healthier or less healthy to drink whatever fluids you're imbibing with the meal or after the meal? And the answer is, I don't think it makes a difference. There are some myths about that, and there are lots of myths about the GI system, but as far as I know, there are no adverse health effects. Now, some people who want to go on diets advocate drinking before, so you sort of get a sense of fullness before you eat, but that's kind of another story. Yes, ma'am.
So in Asia, squatting toilets are common, but I don't know. Looking at your little x-rays, it seems like we should all be squatting on a toilet.
Yes. So squatting actually is a healthier, more physiological way to defecate than sitting on a Western-style toilet seat. It requires a sense of balance, perhaps. But I think it is a better way to do it. Yes, sir. Yes. So the breakdown products of the fat are absorbed by the lacteals, which then drain into the lymphatic system, go through the nodes, and eventually drain into the circulation back via big lymphatic routes, such as the thoracic duct. So they eventually come back to the circulation, but they don't necessarily go through the liver in the same way as the other pathway does. Okay, ma'am.
You talked about the gallbladder's function, but you didn't talk about what happens if you have to have gallbladder removed. How does the system continue to function without gallbladder?
So the question is, how does the system continue to function without a gallbladder? Yeah, so Pete, this is I'm not a surgeon, and any good surgeon will tell you the only good gallbladder is one that they've taken out. But there are possibly some problems when you take out the gallbladder. You don't get the storage function, but it doesn't really interfere with the flow of bile. Bile is still flowing out. And there are, in response to the meal, in most patients, there's enough bile there to continue to act as a detergent. In some patients, there's perhaps we think excessive bile that is released because it's not being stored, and that may result in what we call bile salt malabsorption and diarrhea in some patients who have had the gallbladder removed. Yes, there was a question over there, and then two more questions on the one. Yes, at the back.
Yeah, I was wondering if you can comment on the difference in the digestion and the absorption cycle of vegetarian and non-vegetarian food.
So the question is whether there are differences in the digestive cycle of vegetarian versus non-vegetarian food. So maybe I'll touch upon this a little later in my section, but it's a very complicated question and depends on exactly what you mean by the digestive process, because many different aspects of it can be affected. So I'll talk about it perhaps a little later. Yes, sir.
What makes you feel hungry, and what does it mean if you never feel hungry?
I'll talk about that in a second. I'll talk about what makes you feel hungry, too. Okay, last two questions.
In repairing the bleeding varus, do you literally use a rubber band, and wouldn't the enzymes sort of break that up?
So this is the esophagus that we're talking about. We use, yes, it's a rubber band. I mean, it's it's not an ordinary rubber band, it's a sort of medical grade rubber band, if you will. But the concept is very simple. We put that thing around it. What happens is the blood supply is choked off, there's a clot that forms, and then there's a little ulcer that's left over, and that heals. So yes, there's not usually a problem. One more question?
I'm curious, I was always told that seasickness is something that happens in the brain, and especially now I've heard that we have actually two brains. How come the one brain upsets the other so much?
Oh, yes. Yes. Yeah, so the minor brain, the one up here, is subject to a lot of problems. Well, we'll talk about this. I have a section on the brain-gut axis that we'll come to. So I know you have a lot of other questions, and we'll have other opportunities to ask the questions. If it's okay, we'll just go to the end, because I don't want to shortchange the rest of this lecture. So we talked about structure and function. Now let's talk about sort of some of the common diseases. I've touched upon a few of those, but I really want to get into this in terms of the more common things that we see. So let's start with the gut's lining, right? So the gut's lining is very important. It serves many different functions, and the functions it serves depends on which part of the gut it is in. So for instance, in the stomach, the lining produces both acid and enzymes. It produces an enzyme called pepsin, but the most important substance that the stomach's lining produces is acid hydrochloric acid, and it produces it in a highly concentrated form from the cell that is part of this lining, which we call the parietal cell. This is also, by the way, the process on which proton pump inhibitors, your purple pills and such on, actually block this process of producing the acid. So with this high concentration of acid that is constantly being produced in normal people who are not on drugs, for instance, the question arises, why doesn't the stomach corrode itself? And that's because the stomach has other cells that protect it by producing substances such as mucus, which acts as a buffer. So if you actually look at the stomach lining, and this is the inside of the stomach, the pH is very low, which means it's highly acidic, a pH of 2. But right next to the cell, this mucosal defense layer actually produces a pH of 7, which is very close to the normal physiological state. And this is what the mucous layer actually looks like if you do a scanning electron microscopy of the stomach. You see this silk-like material that's lining these cells. These are the cells that line the stomach. These are the glands that dip into it, and that's where the acid is coming from. And this mucus forms a coat that is protecting the stomach from actually being digested by itself. So the question then arises, why do ulcers occur? So for a long time, for even when I was a medical student, the dogma was that stress, type A personality is, a major cause of ulcers. And it was only about, I guess, 15 or maybe 20 years ago that we discovered the true cause of common ulcers, and that was this bacteria that we call Helicobacter pylori. And this bacterium actually infects the stomach, sits underneath that mucosal layer, and damages the cells of the lining and results in ulcers. So this is a cartoon showing the bacteria. This is an actual photomicrograph. These blue specks here are the bacterium, and this is electron microscopy showing the bacterium sitting on the stomach's lining. This very important discovery was made by two Australians, Dr. Barry Marshall and Dr. Robin Warren. Dr. Robin Warren was a pathologist who, on his birthday, was approached by Barry Marshall, who was a medical student, who asked him for a project. And Robin Warren said, well, I've been noticing funny things whenever I get these biopsies from these patients who have ulcers. I see this bug there, and I don't know what it means. And can you work on this and go back to the records and really show that this bug is associated with the ulcer? And that's how it began, and it was a series of almost heroic investigations that they took, culminating in Dr. Marshall actually ingesting a solution of the bacteria himself to prove that in fact it can cause infection of the stomach, because at that time this was poo-pooed. I mean, these guys stood up and were ridiculed in public forums and said, this is crazy. How can you say that an ulcer is caused by bacterium? And that too in the stomach with all this acid, how can it ever exist? So their efforts were rewarded by a Nobel Prize in 2005. So peptic ulcer disease now mostly, I wouldn't say mostly, but in a very important proportion of patients is caused by this bug. And this causes an increase in acid production that can then result in ulcers in the duodenum. It can cause inflammation and injury to the lining of the stomach that can cause gastric ulcers. And these ulcers can be associated with complications, not just pain. And one of the important complications is bleeding. And this is another example of an ulcer in the stomach that is bleeding. Here you can see this blood vessel here that is pumping out blood. It's an artery. It's not just simply a vein. You can see the pumping, and the blood is just oozing out. So these endoscopists have gone down with the endoscope, identified the site of the bleeding, and then take a needle out through the endoscope and inject that area with a solution of epinephrine just to stop the bleeding. And after that, there's a variety of things that we can do, such as clipping or cauterizing, that can take care of the bleeding. So you see here the ulcer, and then you see this open vessel, which is really a pretty big artery. And then you go down with another instrument here, for instance, which you call an endoscopic clip, and you put it around the artery, and you clip it off. So all this can be done endoscopically, and if 20, 25 years ago, this would have required major surgery. That's not the only cause of ulcers. Now, as we're recognizing this, and more, especially in the Western world, with the use of antibiotics, this bug is sort of fading away. The other common cause is nonsteroidals, drugs such as ibuprofen or even aspirin, that act on the cells lining the stomach that produce mucus, and there's impaired production of this defense layer. This defense layer breaks down, and then the acid has a chance to act and damage the stomach, producing ulcers. So that's another thing that you need to be aware of as a common cause of injury. Just give me a few minutes, and we'll stop and break for questions again. So we talked about the lining of the stomach. Now let's talk about going back up a little to the esophagus, the lining of the esophagus. Now, the lining of the esophagus is very much like the lining of your skin. In fact, this is what it looks like under a microscope, and this is very similar to what skin would look like. It's a very thick, what we call a squamous epithelium, and it's thick because it really has to deal, just like the skin, with a lot of roughness. So when you eat a bolus of, when you swallow and chew, it's really still a very rough, large bolus. It's got its sharp edges, it's got its fibrous material, it's not been broken down. It has to go down very rapidly to the esophagus, and this lining is adapted to make sure that it can handle that and not result in any injury. But this lining is not very good at handling acid, because the esophagus should normally not see acid, and the stomach is where the acid is produced. So, as you all know, and many of you in this room probably have this condition, I certainly do, which is gastroesophageal reflux disease, where contents of the stomach reflux back into the esophagus. And this is because this very important area, which is the junction of the esophagus and the stomach, what we call the GE junction, the gastroesophageal junction, doesn't work properly. There's a ring of muscle there, which we call the lower esophageal sphincter. In addition, there is the diaphragmatic muscle, which separates the chest from the abdomen. And together, they act in concert normally to prevent contents from the stomach going back into the esophagus. But in a lot of people, this mechanism doesn't work properly, and acid actually goes back to the esophagus. And we don't fully understand actually the cause of it. We just know that every time a person who has reflux burps, there's a greater chance that their contents will be more acidic than somebody else who doesn't have reflux burps. And part of it may be due to the fact that many of these patients have either obvious hiatal hernias, or they have pockets of stomach or acid-lined stomach that are creeping up above the diaphragm and are a source of acid. If it was just causing heartburn, you could take care of it fairly easily. But the problem is it has many other ill effects. And one of these has to do with the lining of the esophagus, which I told you is not generally resistant to acid. And in the presence of acid, it can not only break down and form ulcers, but in some patients who perhaps are genetically predisposed, this lining changes its characters. It's almost as if this lining is trying to adapt to this constant reflux of acid and becoming more stomach-like or more intestinal-like, so it becomes more resistant to the acid. And so what you see is a change from, sorry about that. What you see is a change from the squamous epithelium shown on the left, and here's a segment of the esophagus where the lining is changing to where it starts looking more like the intestine. And this is what we call Barrett's esophagus. This is a change in the lining that resembles that of the small intestine. This is what it looks like when you go down the esophagus with a scope. You see these tongues of red mucosa coming up the esophagus. This represents Barrett's esophagus. And I'll show you a video in real time of what it looks like. Here's the tongue of Barrett's that is coming up from. This is a change in the lining of the esophagus. And that's not the only thing. If it just changed by itself, it would not necessarily be such a big deal. But what happens is this lining, because it's not really native to this esophagus, is unstable and unstable genetically. And that means it's at risk for developing cancer. And so in some of these patients, small percentage of these patients who have Barrett's esophagus, they are at risk for developing what we call adenocarcinoma, or cancer of the esophagus. Here you see, for instance, a nodule in a patient with Barrett's, where we think that the lining has now actually transformed into cancer. Fortunately, in this patient, it appears to be superficial, and we can again treat this endoscopically. We can go down with the scope. Here we're showing a cryotherapy. We're actually freezing it. In other instances, we can use radiofrequency to burn it, and so on. If the Barrett's lining is precancerous or cancerous but has not quite invaded the layers of the esophagus, it has the potential for being treated endoscopically. That brings us to another cancer, which is perhaps the most common and most important cancer in the GI tract. It's the fourth most common cancer as a whole. We're talking about colorectal cancer. It's the second commonest cause of cancer death. Lifetime cumulative risk in people in this country is about 6%. It's important to remember 80% occur without any obvious risk factors, unlike lung cancer or other forms of cancer. And it's also important to note that the prognosis depends entirely on the stage of the disease. So the earlier you catch it, the easier it is to live a cancer-free life. And this is important, as I'll tell you in just a minute. So many patients ask me, what can we do to decrease the risk of colorectal cancer? Like I said, 80% of the time, there are no obvious risk factors. And so things that you can't control are your age. Most patients who get this are elderly, over 50. Polyps or inflammatory bowel disease is a risk factor for this. A family history of colorectal cancer is a risk factor. And some patients have these syndromes of cancers where they have cancers of the ovaries or breast, and they are at risk for colorectal cancer. There are some factors that you can't possibly control. There's a diet high in red, processed, or heavily cooked meal, being overweight, especially around the waist, exercising too little, smoking or drinking alcohol. But all of these are, of course, good general measures anyway. Now, the reason it's important to note that the prognosis depends on the size, because colorectal cancer, or at least most forms of colorectal cancer that we know, actually undergo a series of orderly transformations. It starts as this very small ditzil, becomes a polyp, which is still benign, although it's precancerous, it's still benign. And only over time, if we let it grow, that it will become cancer. So it provides us a window of opportunity to intervene before it becomes cancer. And that is why it's very important to undergo screening. Screening colonoscopy, which we recommend for everybody over the age of 50, is the gold standard. And you can see here a polyp that is found on a screening colonoscopy. There's a lot of talk about virtual colonoscopy, which is a CT scan, which mimics what you would do with a colonoscopy, except you don't have to actually put a scope in it. And these are side-by-side images of the same lesion on a screening colonoscopy as a virtual colonoscopy. Currently, virtual colonoscopy is not recommended in favor over a screening colonoscopy because it's felt by experts not to be as sensitive, particularly for smaller polyps, but that may change in the next few years or months even as the techniques evolve. Here is a video illustration of a polyp that we are going to remove by an endoscopic means. This is a colonoscopy. Here's a polyp. You see that we just injected some saline there to lift this polyp, and we're going to, well, when I say we, I'm talking about the endoscopist here, it wasn't really me, put a snare around that polyp and basically guillotine it off. It's a lot of fun, believe me. And it's gone. And then you take care of anything residual, and that's what's left, and that little hole heals over the next few days, typically without any problems. There are some occasional complications like bleeding and perforation, which are very, very rare. Okay, finally, I want to end with the... Okay, well, you know, we're in that part of the anatomy, so I thought I'd just finish up, because it's actually a very common complaint, and most people not quite sure what hemorrhoid is, even though a lot of people suffer from it. So hemorrhoids are caused by successive straining, which in turn are caused by changes in the diet or hormonal changes, such as that occur with pregnancy. But essentially, the hemorrhoidal tissue is part of the normal anatomy of the rectum, and it's part of the continence mechanism. And actually, these are very vascular, spongy tissue collections that are part of the rectum. It's when these veins get engorged that these hemorrhoids enlarge and then can get inflamed, sometimes can prolapse and cause problems with pain, irritation, and itching. So I just wanted to finish that, and I'll now open this section up for questions before we move on to the next. There was a question over there, the gentleman there.
So if Helicobacter pylori is present, is it present in all stomachs? And if it is, then why does ulcers develop in certain stomachs and not others?
So the question is Helicobacter present in all stomachs? And if it is, why do ulcers only develop in a few patients? So both are very good questions. It used to be highly prevalent in the Western world. And perhaps in the generation before mine, I guess the prevalence was very high. But because of changes in social hygiene and the way we live, the prevalence in Western countries has declined significantly, although in other parts of the world, such as in Latin America, it is very high, and prevalence rates may exceed 50%. Typically now, we don't see it very commonly. Even when we see it, it can, and most of the time probably does occur in an asymptomatic state. Most patients who have Helicobacter will not develop ulcers, and only a small percentage will. In fact, it has been argued, and many still argue, that the organism is actually playing a beneficial role to some extent in patients. And there is some epidemiological evidence to suggest, for instance, that it may actually protect against reflux, even though it may cause ulcers. It may actually protect against reflux. So it's one of those stories where there's probably good and bad to it. But if somebody does have ulcers, and they have Helicobacter, there's no question that we need to eradicate that, and we eradicate that now with fairly simple antibiotic regimens. Question? Yes, ma'am.
Back to gallstones, I heard female fat in certain cases.
Yeah. The question is back to going back to gallstones. The risk factors are, I didn't say this, I'm just quoting, female fat in 40. Yes, it's true that more women are prone to gallstones, and that obesity is a risk factor. they are more common with increasing age. And actually, there's a fourth F, which is fertile. So that's sort of more equivocal whether or not that's a risk factor or not. So there is some truth to that. Yes, the back.
What is it about heavily cooked meats that makes them bad for your colon?
Sorry, just repeat the question.
What is it about heavily cooked meat that's a problem? You said that was a risk factor for...
Yes, so heavily cooked, they're processed, there's probably a production of some toxins with heavily cooked meat that may be harmful to the lining of the intestines.
When you have acid reflux, what's your opinion about using acid suppressant as treatment?
Yes, so the question is, what is the opinion on acid suppressant for reflux? That is the mainstay of treatment for acid reflux, is the use of acid suppressants, particularly what we call proton pump inhibitors.
I understand that the sphincter requires acid to close, and if you suppress it...
Yes, so that's a very astute comment. We are not treating the cause of the reflux. We're simply making the refluxate less harmful by taking away the acid, so it won't cause damage. So there is still reflux going on, but it's no longer acidic, so it doesn't damage the lining. But you haven't addressed the underlying problem, which is your sphincter is not functioning properly. Some drugs are being developed to counteract that, but at the present time, we're really doing symptomatic therapy. Yes, sir?
Is it true that eating spicy food also causes ulcer?
No, it's not true. Does that make you happier? Good. The question is, does spicy food cause ulcers? In fact, there's some evidence that spicy food, which this is another conversation, capsaicin, which acts on certain receptors and lining the nerves, may actually protect against ulcers. Last question, then we need to move on.
So, too many questions. So, where did that polyp go?
Where did it go?
And then, are you going to comment all on this evolution of gastric bypass surgery and how that sort of upsets what seems to be a very delicate balance between...
So I can comment on that later at the end. The last question is, how does gastric bypass affect this whole process? And the first question is, where did that polyp go? So we collect that polyp, actually. We go in and grab it. We have means to grab it, basket it, and bring it out, and give it to our pathologist. We really want to examine it very carefully, make sure there are no changes that we would be surprised by. Okay, let's move on. Okay, so let's talk about an emerging field, the enteric microflora. You're not aware that you had 100 trillion roomies, but that's true. 10 times more than all the cells of your body combined are in your gut. 60% of your stools, if you dry them out, will be these bacteria. There's some fungi and some protozoa, but really it's the bacteria that we're concerned with. And they're actually very good for us, by and large. They do many important things for us, and a list here, which I'm not going to go through, but perhaps the most important thing is that they salvage energy. So a lot of the food that we can't digest because we don't have the enzymes, they actually are able to digest, and some of the byproducts of the digestion are useful nutrients for the lining of the colon, such as short-chain fatty acids. They also produce vitamins, such as K. They're helpful in absorption of iron and calcium. Very importantly, they aid in the development of the protective function of the intestinal barrier. They maintain it, and we'll talk about that in a little bit. But also, they outcompete harmful bacteria. So these are your allies, these are your friends that are shutting out the invaders at the gate and telling them to stay away because they're just sort of hogged all the posts that are there to occupy. And we'll talk about that and how important it is. And then, like I said, they are actually talking to the epithelial cells, the lining of the cells, and the immune cells in the gut, and maintaining our system in a very finely tuned state of health. The types of bacteria in the, are many, but in the colon, which is really where most of the current research is going on, there are really two broad phyla of bacteria. One we call Firmicutes and the other Bacteroidetes. You don't have to really remember the names except that there are two broad phyla, and then within these there are nearly about 500 species of different bacteria. And I was going to just illustrate this concept of maintaining friendly bacteria by this disease which we call C. difficile colitis, Clostridium difficile colitis. You may have read about this. It's very common. It's one of the commonest hospital-acquired infections. And this occurs because these friendly bacteria are somehow destroyed by antibiotics that we use. So here is a cartoon illustrating friendly bacteria in the lumen of the gut. This is your epithelial lining. You come into the hospital, either you're infected by somebody else or typically you're given antibiotics. Many of these friendly bacteria are sort of caught in the crossfire, the innocent bystanders, and they die. And then you have this, like I said, this barbarian at the gate, which is waiting for this opportunity and overgrows because the defenders are no longer on guard. And this then destroys the epithelium, and you can see ulcers and pus in the colon. And this is a process we call C. difficile colitis, and it's a very, very common cause of morbidity and one of the more serious problems that we face in the hospitalized population today. Of course, there are other forms of harmful bacteria, which I'm not going to have the time to go to. You've all heard about E. coli and uncooked meat, and then the salmonella from poultry products. These cause similar processes, either in the small bowel or the large bowel of inflammation. These are not necessarily due to problems with our own defense. These are problems because we just ingested a massive dose of these foreign bacteria, and they're so virulent that they can overcome whatever defenses we have. So I'm going to switch a little here about these bacteria and an emerging role for them outside of the gut. Okay, so we have a big problem, no pun intended, with obesity in this country, but in most of the world now. And as Americans, we love to blame somebody else for this. So here's a cartoon that illustrates, what this person is going to do as far as his weight is concerned. And of course, the other problem is, of course, we don't exercise enough. But, all of this is now no longer, I'm joking, no longer important because we found the real culprits, and these are the bacteria in our guts. So this is elegant series of studies, and a lot of this work is ongoing by Jeff Gordon, his lab in St. Louis. Was shown that maybe it's the change in the composition of the normal bacterial content in our colon that may contribute to obesity. So that they've been looking at this, studying this in mice, and they show that in obese mice, this ratio of these two big phyla, which I said, Bacteroidetes and Firmicutes, is changed. And in fact, this results perhaps in greater energy capture. These bacteria may be more efficient at energy capture from the undigested food that we take. And the theory is that over time, this energy, this excess energy is available and may contribute to increasing weight in the bodies. Now, this is controversial. It's still work in evolution, so take it with a little bit of pinch and salt. But this is a very hot area of research. And this really brings us to the question of what are we? I had a slide here, which has not come up, but of a coral reef, for instance. A coral reef is not just the polyps that make the coral. A coral reef is a complex, very large ecosystem. Many, many different kinds of animals and many different kinds of plants make up the coral reef. And we've always thought of ourselves as human beings as kind of, sort of single individuals. But I think what this research is now telling us is that we are, in fact, like coral reefs. It's not just us. It's not just this body. But it's these trillions of neighbors that are residing within us that may actually contribute to our health. And it's not just a philosophical point. It's a practical point, because that means if we are going to affect the health of our bodies, another target, instead of just our own cells, is these bacteria. So if we can come up with drugs, for instance, and we call them drugs, but anything that can manipulate this environment to a healthier one, we can affect our own health. And so this is really going to be the next 10, 20 years, an amazing area for discovery. And those of you who watch the news should really pay attention to this, because this is where some new drugs will come up, both antibiotics, but also perhaps drugs for diabetes, obesity. And this will also provide major insight into the kinds of foods that we should be eating, and that goes back to one of the question that was raised about how much vegetarian versus meats and so on. So this is something that's still in evolution, but we're all very excited by this area. Now, we should talk a little bit about a related subject, which is probiotics, which is now obviously you can't walk past a store now without an advertisement for some probiotic or the other. And these are live microorganisms which, when administered in adequate amounts, should confer a health benefit. The two most common kinds of probiotics are lactic acid and bifidobacteria, and these are all part of the so-called normal flora that we have inside us, except now we're taking it in therapeutic doses. And these can come in the form of active culture yogurts or just as supplements. Now, despite all the talk, there's still a lot of research that needs to be done about the actual health benefits of probiotics. And these are only some of there are only some areas where they have had what we think a proven benefit. So in certain kinds of diarrheas, certain forms of inflammation, particularly after surgery, candidal vaginosis, some forms of eczema. In all others, the health claims are still to be really validated. But here's how a probiotic can help with antibiotic-related diarrhea. So these are actually patients with Helicobacter infection who were treated with antibiotics and put either on a placebo or on probiotics. And the ones who were on probiotics had much fewer diarrhea days than those that didn't, suggesting that it is in fact restoring the normal flora to some extent. This also brings up the question of fiber and how can we use food to change the flora. Now, some of you may know, but others may not, that there are actually two forms of fiber. There's the soluble fiber and there's the insoluble fiber. It's the soluble fiber that really affects the bacteria in your gut because it's the source of complex carbohydrates that they can digest. So this is what we call a prebiotic effect as opposed to the probiotic effect, where you're actually taking healthful bacteria. In prebiotics, you're taking foods or other substances that change the flora. And so some of the fiber products fall in that category. Fiber can also improve sugar control in type 2 diabetes. And then there's the other kind of fiber, the insoluble fiber, which really doesn't do that. It's not necessarily digested by the bacteria, but it does add bulk to the stools and makes the flow better, improves constipation, and reduces pressure in the colon. And reducing pressure in the colon is important for a variety of different reasons, but one of the very common diseases in the Western countries is what we call diverticulosis, in which because of high pressure in the colon, because of constipation, and because of reduced stool bulk, you get these weaknesses that erupt in the wall of the stomach, resulting in pouches that we call diverticula. And most of the time they're asymptomatic, but in some patients they can cause inflammation or bleeding. So that brings up the issue of, okay, so we have all these trillions of bacteria living inside of us. How do we prevent them from getting everywhere? And this is a very important role that the gut plays. And this is part of what we call the mucosal defense system. So the gut lining is actually quite tight. It absorbs food mainly through the cellular pathways. That means the nutrients have to first enter the cell and then go into the blood vessels. And in between, the neighbors are very close together, and there's lots of proteins here that act to form what we call tight junctions that prevent leakage of material across this lining. Another part of the defense system is an immune system that lies just underneath the surface. So if you look underneath the epithelial lining, there are all these immune cells, lymphocytes, plasma cells, that are right there, ready to handle any breach of this lining and attack whatever comes their way. And so it's a very complex system that is acting solely to regulate this barrier. Now, there are some conditions in which something goes wrong with this function. And the common example of this is inflammatory bowel disease. And most of you are familiar. Inflammatory bowel disease is a group of diseases which we don't really know why they occur, but we classify them as either having Crohn's or ulcerative colitis. And the difference is several-fold. Crohn's is a patchy disease that affects both the small bowel as well as the large bowel. Ulcerative colitis mainly affects the colon, and acts in a diffuse way, either in the distal part or throughout the colon. Crohn's disease also affects the entire wall of the gut, whereas ulcerative colitis only affects the lining of the gut. And these are what the endoscopic pictures look like. The other difference between Crohn's is that it can cause painful anal conditions. It can cause fistulas, which are tracts that form between the rectum and the skin. And that can, of course, be disfiguring, but can also be a major health problem. Now, like I said, we don't know what causes it, but we're beginning to put together the pieces over the last few years. In some patients, this lining is leaky to begin with. So what normally happens is in health is there is some leakiness. It's not a perfect, there's some leakiness. Some bacteria or other proteins may get through. And what happens is that the immune system responds, checks those bacteria, but also maintains the inflammatory response in sort of some kind of control. In patients who have inflammatory bowel disease, either this membrane is too leaky that overwhelms the immune system, or the immune system itself reacts in an aberrant fashion and is too vigorous in attacking these bacteria and forms products that in fact start destroying the lining itself. And that's what we think causes inflammatory bowel disease. Here is a video, for instance, of somebody who has ulcerative colitis. And this is sort of the normal-looking mucosa here, but now we get into a part of the colon that we start seeing ulcers, redness, and there's actual pus here that is coming out. And you can imagine these patients having this in their colon. They're having diarrhea, blood, terrible cramps. So it's a very debilitating and disabling disease. So let's move on to other kinds of diseases where the immune system may play a role. And one of the common ones is celiac disease or celiac sprue. And for celiac sprue to occur, and there's a lot of publicity about this, and many of you are aware of this, you need to have two things. You need to have a genetic predisposition. We know you have to have a certain class of gene, important for the immune response. And you have to be exposed to this protein in wheat or other cereals that we call gluten. It's quite common. It's supposed to affect between 150 to 1 in 200 adults. And it starts eating away at the lining of the small bowel. Here is a normal small bowel. You can see nice villi on histology. And here's a bowel with celiac disease. You see that there's edema, there's swelling, and there's what we call scalloping of the folds. And on histology, these villi are lost. So these villi, as I mentioned earlier, are very important for absorption. And when you lose those, you're no longer able to absorb those nutrients, and you have diarrhea. But diarrhea is actually maybe just the tip of the iceberg in these patients. Many patients may have silent or atypical disease, and there's an increasing and growing list of non-intestinal manifestations that are linked to celiac, such as arthritis, liver disease, or even certain neurological disorders, even including autism. The problem with celiac is the gluten, the antigen, is present in a lot of foods that you don't even suspect. So it's actually very difficult to maintain a strict gluten-free diet. But people are working on other ways to treat this. So I just want to end this section by saying it's not a true allergic disease, though. Many people think of this as a food allergy. It's not a food allergy. The body is not reacting directly to the gluten. The gluten is triggering an immune response, which is somehow wrongly directed at the body's own intestine. And that's different from a true allergy. We have started seeing increasingly true allergies in the bowel, affecting the bowel. I'm not talking about systemic food allergies like peanut allergy, which cause systemic problems. But here's an example of what we call eosinophilic esophagitis, first recognized in children, but now increasingly being recognized in adults, where some unknown antigens, perhaps in the food or in the air that we breathe, are triggering this immune response and associated with the presence of these inflammatory cells that we call eosinophils. And you can see the lining of the esophagus, which normally should be very smooth, is corrugated, what we call a cat's esophagus or feline esophagus, because that's what it looks like, and causes all sorts of problems with swallowing and pain. So I'll stop here very quickly for any questions, and then we'll just have another 5 or 10 minutes left. Questions, sir?
What
is the belief that goes wrong which leads to incontinence in men or women?
The question is, what leads to incontinence in men or women? It's a good question. It's a not a straight, there's not one answer to this. In women, one of the commonest causes is childbirth, either multiple childbirths or trauma sustained during childbirth, either a perineal injury with an episiotomy that was too deep, or just traumatic delivery, and there was tearing of the pelvic floor muscles involved in maintaining continence. In some patients, there's some nerve injury. Patients who have diabetes have a combination of perhaps nerve injury and some muscle injury. So it's very difficult. As we grow older, some of the nerves that are responsible for maintaining the muscle tone are either lost or not as vigorous as they used to be. So there's a combination of factors, and it really depends on each patient. Has to be individualized. Yes, one more question?
Is there any research going into what the composition of an optimal stomach is?
The composition, is there any research going into the composition of an optimal stomach?
What's a normal optimal stomach?
Do you want to clarify that? You mean in terms of size?
No, as far as the bacteria that's in there.
Oh, so you're talking about the bacteria. What should be a normal? Well, yes. In fact, David Relman from Stanford has done a lot of work on this, and he's still engaged in carefully typing the kinds of bacteria that are present in normal individuals and how they evolve from sort of childbirth all the way to adulthood. Because when you're born with a sterile gut, and as you start drinking your mother's milk, you start getting bacteria introduced, which is one other healthful reason for breastfeeding. And so, yes, there's a lot of work that's being done. Just that, in fact, the NIH has commissioned tens of millions of dollars to sort of really map out what they call the human microbiome, which is, you've heard about the Human Genome Project, which is to map out all the genes and to characterize the genes, and this is to characterize the bacteria both in health and disease. So it's a work in evolution. I think the next 10 years, you'll see a lot of that. Yes, ma'am?
How do you cure diverticulitis?
So the question is, how do you cure diverticulitis? So I want to distinguish diverticulosis from diverticulitis. Diverticulosis is the condition in which you have these sac-like outpouchings, and then one of the complications is diverticulitis. There may be a minor leak from that pouching, and there's an inflammatory response, and that's diverticulitis. And that you treat with typically the first bout with antibiotics, and it usually gets better. If it happens on a recurrent basis, you may have to take that segment of the colon out. Diverticulosis per se, if it's asymptomatic, you don't necessarily have to do anything. We don't think it's reversible. You can do stuff to prevent it, and that is to increase the bulk of your stools, and typically we do that by increasing the fiber. Ma'am? Yes, ma'am.
You mentioned autism very briefly in connection with celiac. Can you elaborate just a bit about that connection, please?
So it's a much part of a much broader question that I would probably try to say to the end. It's a connection of where do some of the insults that occur in the rest of the body originate. There's a body of thought that not just for autism, for Parkinson's, for instance, there may be insults either in the form of foreign proteins or bacteria that are getting access to the body and maybe eliciting either immune responses or by direct invasion causing problems. But we'll talk about that later. One last question, ma'am, and then we'll move on. Yes.
What's the doctor's name that's doing the typing of the types of bacteria?
Here at Stanford? Yes. David Relman, R-E-L-M-A-N. Okay. Okay. Let's talk about the brain-gut axis a little bit. And that may have some relevance to this question that was asked. So how do these two brains... I would actually, if it was me, left to me, I would switch the labels around, but most people won't let me. So how do they talk to each other? That's what we call the brain-gut axis. So they communicate via hormones. That's one way. And somebody had asked the question earlier, what makes you hungry? So one of the hormones that makes us very, very hungry is ghrelin. It's produced by the stomach, And it's the most potent factor that drives hunger that we know of. And it signals to the brain, makes the brain act in a certain way to get energy, get food, but also signals to the rest of the body directly or via the brain to alter the metabolic status, alter the energy status of other tissues such as fat or skeletal muscle. And it's communicating this along with other signals that are coming from adipose tissues, such as this other hormone called leptin, which tries to counteract some of this, which is an anorexic hormone. That means it decreases the appetite. So together, these signals act in the brain, particularly in the hypothalamic area, and regulate whether we're hungry, regulate how much we eat, how full we feel after a meal, and what we do with that energy. How is it stored? Where is it stored? And what are the consequences of that? The other way that the brain and gut communicate is through nerves. Now, there's another nervous system. We talked about two nervous systems, the central nervous system, the enteric nervous system. There's a third nervous system, which is the autonomic nervous system, which actually is responsible for communication between these two brain systems. That's classically divided into the sympathetic and the parasympathetic nervous system. We don't have to go into details, but one of the more important parts of the parasympathetic is this nerve called the vagus nerve, which you can see here from a rat's stomach, is in intimate relationship with the wall of the stomach and is gathering information on how much the stomach is distending, is gathering information on what the chemicals inside the stomach are, what the pressures are, and conveying them back to the brain, where it can trigger reflexes such as satiety, you start feeling full, and if you eat too much, you start feeling nausea, and other reflexes. In fact, this nerve can be stimulated artificially, and there was a company that was actually doing this for treating depression. So they were planting electrodes on the vagus in the neck, and this was approved by the FDA, not just for treating seizures, but for depression. And again, sort of lends credence to the fact that what you eat may in fact influence how you feel. So this is actually another very exciting area of research that we're doing. This vagus is largely sensory, but it also carries impulses in the other direction from the brain to the gut, and through other communications can affect whether the gut contracts or not. Here's an experiment that was done in the 50s, I think, on a medical student in a prominent medical school, not Stanford, thank God. But here's a student who was brought in for an experiment by his professor. They put this large sigmoidoscope in the rectum and monitored the pressures in the rectum. And about 5 minutes into the procedure, everything was going fine. You know, the contractile state of the colon was relaxed as you can be with a big rigid tube. But then this professor calls out and says, "Wow, look at that bad, ugly cancer." And you can see now, just hearing that, the colon and the rectum of the student started contracting like crazy. And then a few minutes, let this subject suffer a little, and then they explain that, oh, it was just kidding, it's a hoax. And of course, the contractile state of the colon came back to normal. Now, what the student did to the professor, we'll never find out. It wasn't part of the published literature. But this is an illustration of how the brain actually can affect you. And this is, I think, the basis of gut feelings. We all have felt something like this. And we're now beginning to understand how these gut feelings occur. What is the biological basis of this? Again, the brain is producing certain hormones. For instance, if you feel nauseous under stress, some people do just feel nauseous under stress, feel just that they're having a bad case of indigestion. That ulcer-like feeling is not really an ulcer. And that's the stomach contraction slowing down. The gastric emptying is slowing down, makes you feel full and nauseous. And that is part of the vagus communicating to the stomach. Through this hormone that we call CRH, corticosteroid-releasing hormone, which is part of the stress system in the brain. In the colon, the same hormone produces increased contractions and diarrhea. And this is why the typical, right before a test, you have to go to the bathroom or before a stressful situation. And that's the basis of this. So this is really the gut feeling that we all experience. Finally, there's another communication between the gut and the brain, and that's through the pain-sensing fibers. So these nerves are not really involved in pain as much as these. These go through the spinal cord and sense pain. And this is important in conditions such as the irritable bowel syndrome, where we know that patients are much more sensitive to distension of the colon. So we think that their pain fibers or their pain-sensing system is hyperactive. So if you distend a normal volunteer, again, one of the things gastroenterologists like to do is put a balloon and test people's responses to it. You can see that normal volunteers don't really report a lot of pain, whereas if you have IBS or irritable bowel syndrome, you're really shooting off the chart here in terms of your pain response. And this occurs in association with change in bowel movements, and this constellation of symptoms is part of the irritable bowel syndrome. We now know with new research that the brains of patients with IBS actually react differently to GI stimuli. So it's really, it used to be said it's in your head as sort of a pejorative way of saying you're making it up for patients, but we now know it's really in the head, but there's a biological basis for this. And if you do PET scans or functional MRIs of patients, you can see different parts of the brain light up in response to the same stimulus in patients with IBS and with different intensities. And we're now beginning to understand what is the biological basis of that. That's not the only problem. Irritable bowel syndrome is a very complex syndrome. It's actually a very good example of where both the brain and the gut are affected. You have problems with the brain, you have stress, you have a hypersensitivity of the nerves, you have alteration of bacteria actually in the colon, which is becoming an important factor, and you have alterations in the immune system, the motility, and we still don't know how all these pieces come together to make up irritable bowel syndrome, but there's active research going on in this field. So in conclusion, I think we've hopefully had a good overview of the structure and function of the gut, particularly with regard to the nervous system. I hope you have a better understanding now of the meal that you're digesting, which is now making its way to the last part of your small bowel. Talked about the gut's lining, and hopefully many of you haven't had reflux. Talked about this ecosystem that's within our body, which is really, really important. Talked about the gut's immune system. I talked about the brain-gut ecosystem. As I started off by saying, the gastrointestinal system, we've really scratched the surface, obviously, in an hour and a half that I've had. But you can see how complex it is, how many different systems are involved. It's unlike any other GI, any other system in the body. And I hope I've convinced you that it is the most important system in the body. Now, I know we have a little time, so I'm just going to just one more slide I want to show you because I think it's important as we go forward in terms of the specialty of gastroenterology. I've illustrated a lot of the points with endoscopy. I've shown you how endoscopy is so useful diagnostically, and I've shown you how useful it is therapeutically in some instances. And in a lot of ways, where the field is going is this minimally invasive way, putting a scope through your mouth or through your rectum, is going to replace a lot of the traditional surgery. Many of you may recognize this figure. This is Dr. Halsted, father of modern American surgery. And he was the one who really sort of came up with the concept of sterile surgery, using rubber gloves, using carbolic acid, using, he was not with carbolic acid, but using rubber gloves and using sort of special rooms which were in a sterile environment. And he's taught generations and generations of modern surgeons throughout the world. I bring him up because we talked about the gallbladder, the gallstones, and Halsted was actually called by his mother because she was having this pain on the right side. And he went to her and immediately diagnosed her as having a red-hot, inflamed gallbladder, put her on the kitchen table, took out his kitchen knives, sterilized them as best as he could, and opened up the abdomen, giving her some ether, and took out the gallbladder and drained it of his pus and probably saved his mother's life. So that was the beginning of cholecystectomy, actually, back then. Since then, it's evolved to this laparoscopic form of surgery. Ironically, by the way, as an aside, Halsted himself died of complications of cholecystitis. He had the operation, but then he died post-operatively, which is just one of history's ironies. So we have traditionally been going through the skin and the wall to get at these organs and remove them. And a few years ago, a group of us came up with this concept of trying to do this through the mouth or through the rectum. And here's a cartoon that illustrates this. Here's a scope that's going through the mouth, down into the stomach, making a hole in the stomach. Push the scope out, and then going towards the gallbladder, dissecting it, and then cutting it off, and removing it, and bringing it out through the mouth. So actually, since we started doing this in animals several years ago, now there are a few hundred patients that have been done, mainly through the vagina, not through the stomach as much, although a few have been done through the stomach. The stomach is technically more difficult because we don't have the right tools. But this whole process, this whole approach is called NOTES, Natural Orifice Transluminal Endoscopic Surgery. I'm going to show you an example of the first human case of NOTES, taking out the appendix through the stomach. So this now you're already in the abdominal cavity, you've already made a hole in the stomach, the scope is out there, right here in the right lower quadrant where the appendix is, and you're putting in a tool out there, you're cutting away at the base of the appendix. Just like you would remove a polyp, you can actually remove this. You're snaring that, and you're taking it out, cutting it off, and you're capturing it. And this was done by actually Dr. Reddy and Rao in Hyderabad, India. And once you have that cut off, you just irrigate the area and you capture the appendix and you pull it out of the mouth. Okay, how many of you still hungry? All right, so I hope you've learned a little about GI diseases. All right. Thank you very much.
Well, I think you must agree with me that this was really quite a tour de force. I do take note of the fact that we've been here for almost 2 hours, which means that you have about 2 hours to get home for your next either meal or evacuation, your choice. But I think, Dr. Pasricha, thank you very much for that wonderful presentation.
For more, please visit us at stanford.edu.